So thanks a lot, Zubin, and I think you hit the nail on the head when let's have a little bit of fun. We got some people here that have done a lot of this research, but also a lot of people in the audience who are going to help us understand how to take this research, or some of it, into the clinical arena. And so I asked Connie and Akshay to help me out to share some of their insights and perspectives from the fellow side of things, both some good science that Akshay will go over, and then a lot of what the fellows were involved with Connie. These are my financial disclosures, the sponsors who fund the research we do at the DCRI, and both Connie and Akshay have no disclosures to reveal. We decided we better just be up front here as we're going through this, and apologies as needed. But what I'd like to do in the next 45 minutes, and we're going to spend a little bit of time going back and forth between me and Connie and Akshay, but one is to talk about the roles at the ACC that Duke had, both leadership and at the scientific sessions. Really a tremendous effort on the part of the fellows for participation in a variety of important forums. The late-breaking clinical trials obviously get a bunch of science, but that's where much of the research that's going to impact our daily lives, taking care of patients. So we'll go over some of the trials that Duke was involved with, and some of the selected trials I think of our importance that Duke was not participating in. And then obviously think about some of our coverage and awards. So I showed this last year. John Alexander's done the same thing. This is absolutely phenomenal. I think, Chris, you would agree that the volume of abstracts meet the expert participation. Duke faculty on late-breaking clinical trials, including some fellows as well this year, chairing some of the scientific sessions, being part of the ACC symposiums, and then invited presentations. Over 160, almost 170. And if you look in the bottom of the slide, last year at the same meetings, it was 144. So tremendous participation, and it's getting more and more impressive. And having our presence there because of the breadth of the research we do, the clinical care that we give, I think reflects a lot on both our research enterprises, our clinical enterprises, and our heart center. So I'm going to turn it over now to Connie to go through some things, and then I'll be back up in a few minutes. Thanks, Connie.
Great, thank you. Just get this on here. Great. Well, I have the fun job of presenting the fellows' participation at ACC. And among the general cardiology fellows, the advanced clinical fellows, and the DCRI research fellows, there were a total of 15 fellow poster presentations. As you can see from this slide and the next, fellows from each of these groups contributed, and we actually had 2 first-year fellows who managed to sneak away from their clinical duties to also participate. We were very proud to have 3 Best Fit Poster Award winners. This means that their abstracts were considered to be in the top 3% of the FIT submissions. The first was Tariq Ahmad, who presented work that he did with his primary mentor, Mike Felker. They looked at patients with chronic heart failure in the ACTION-HF study and found that biomarkers of myocardial stress, injury, and inflammation did not change with exercise training. This was the first assessment of this question using randomized clinical trial data. Next, we had Rolf Harskamp, one of the DCRI fellows. He worked with Renato Lopez on a secondary analysis from the PREVENT-4 trial. They found that patients with extracardiac vascular disease had higher risk of both vein graft failure and worse long-term clinical outcomes after CABG surgery. But they postulate that vein graft failure is not the sole mediator of these worse outcomes. Last, Amit Vora, one of our first-year fellows, was the 3rd poster awardee. And I'm proud to announce that he won not only a Best Fit poster, but also a Best Overall poster in his category, which is a great achievement. So Amit, working under the mentorship of Tracy Wong, looked at data from the Action Get With the Guidelines registry and looked specifically at fibrinolytic eligible STEMI patients who presented to non-PCI centers and were subsequently transferred to PCI-capable facilities. They found that likelihood of achieving primary PCI within the guideline-recommended 120-minute door-to-balloon time was less than 50% for patients who had a transfer driving time of 30 minutes or greater. And they suggest that perhaps these patients might be more strongly considered for lysis therapy. I'd like to pause for just a moment here. I'll admit that I included a lot of these fellow and faculty photos because everyone likes photos and I wanted to keep you interested, but I also wanted to highlight the important contribution of the mentor-mentee relationship and the contributions of mentors to the work that I'm presenting here today. So in addition to the 15 poster presentations, we also had 5 oral contributions from fellows. The first was Shreek Vamulapalli, who worked with Leslie Curtis looking at peripheral arterial disease in Medicare beneficiaries. They found that 30% of patients undergoing lower extremity amputation did so without any prior arterial assessment, and this represents an area for potential quality improvement. Next, we had Paul Hess working under the guidance of Ken Mahaffey, and he did an analysis from the TRACER trial looking at the incidence and predictors of sudden cardiac death after hospitalization for non-ST segment elevation myocardial infarction. They found that sudden cardiac death accounts for approximately 40% of CV mortality, and they developed a model that had better discriminatory power than currently used clinical indicators of sudden cardiac death or predictors of sudden cardiac death. Emily O'Brien is one of our DCRI fellows who worked with Eric Peterson and looked at older NSTEMI patients from the CRUSADE registry. They found that the obesity paradox, in which patients with higher BMIs have paradoxically lower mortality, persists despite adjustment for up to 3 years after index hospitalization. I did work with Sunil Rao looking at the relationship between transradial percutaneous coronary intervention experience and procedural metrics. Using data from the CATH-PCI registry, we found that there is a learning curve among U.S. operators for radial PCI procedures, and that the threshold for overcoming this learning curve is approximately 40 cases. These data should be informative for training guidelines for radial procedures, as they currently do not exist. And finally, Matt Sherwood worked under the mentorship of Rick Becker on an analysis from Rocket AF. They found that patients with temporary interruptions of anticoagulation had worse clinical outcomes for both stroke and bleeding compared with patients who had no interruptions. However, the risk conferred by these interruptions was similar between the patients treated with rivaroxaban versus warfarin. And for many of you who may not know, Matt's research was profiled on theheart.org, which is really a great honor, especially for a fellow. And it speaks to not only the quality of the science, but also the interest in the community in his research. So congratulations to Matt. Now, we had a lot of fellows who also contributed through co-authorship on presentations, and you can see the complete list of these co-authorships here. John Vivalli presented two clinical cases at the clinical sessions of ACC, and Melissa Burrows-Pena was one of the FIT planning committee members. She was also a moderator for the Outside the Box FIT session on alternative cardiology career paths. And Paul Hess is a FIT member of the ACC Electrophysiology and Electrocardiography Committee. Now, Tarek presented a clinical heart failure case to Dr. Bayshore in the FIT Forum Stump the Professor session. This was one of his first slides from his slide set. And when I first looked at it, I thought, A, I don't get it, and B, it's a little weird and disturbing. Now, it turns out that to stump is also a cricket term that involves breaking the wicket with the ball while the batsman is out of the crease. I sort of get it a little bit more, but it's still kind of weird and disturbing. Now, no talk about the Fellows' participation at ACC would be complete without mention of the Fellows blog. A big thanks to Matt and Tarek for really spearheading the efforts and organizing these interviews. But as you'll see, a lot of the other fellows participated in the interviews, and you'll see a very impressive list of interviewees on the far right-hand corner. Finally, I'd like to highlight this Women in Cardiology series. This was an idea that was conceived of and executed by Pratithi Kazani. And this was the second national meeting where she ran around the conference holding a microphone and interviewing top female leaders in cardiology. And you'll see that 3 of our own are included in this year's roundup. So I think over the past few minutes, I've really shared that the Duke Fellows had a very strong presence at ACC. I think this reflects not only a very talented group of individuals, but also the tremendous opportunities and strong mentorship available to us at Duke. So thank you for your attention.
So thanks, Connie. So what we're going to start now, first with me and then with Akshay, is to go through what I call the parade of trials that really reflect, I think, some of the cutting-edge science. And what I'm going to plan on doing is probably stopping at various points, either when I'm speaking or when Akshay's speaking, and kind of ask people who have interest in specific areas about what they think the implications may be in our practice. So you're not just listening to the three of us for the next half an hour. So the first trial I want to mention is the PREVAIL trial of the Watchman device for two reasons, actually three reasons. One is it had the biggest shake-up there in the rumor mill because, as many of you probably know by now, that one of the first presentations on Saturday morning, 7,000 people in a room, and they had to stand up and say it wasn't going to get presented because the embargo was broken by the sponsor, that they sent around an email with detailed results of the trial 3 hours before the embargo was lifted. It happened. I think the ACC made a very difficult decision. And so, unfortunately, we haven't seen a lot of the data because it wasn't simultaneously published. And so we still have some questions about all the different endpoints that they had and how they were analyzed. And you can see the primary endpoints here. I think the important message here is that we gained a lot more experience with this device with new investigators, not just the old set of investigators, and that at the end of the day, they showed that the event rates were comparable to what they would have anticipated, and the fact that new investigators, when trained appropriately, also had very good implant success with low event rates. And so I think that likely this will satisfy the regulatory requirements, if I could put on my thinking cap or get my crystal ball out. But I think likely that this is going to achieve success through the regulatory pathways moving forward. The next one was, I thought, very interesting, is an analysis. It was actually an extension of analysis that had been previously published by a group looking at mummies and doing CAT scans on them to look at coronary artery disease. And they expanded into a number of different cohorts and showed similar patterns that, in fact, as people aged, even many years ago, that there was increasing risk of atherosclerotic disease and burden of atherosclerosis, even in what we, for all of us now on paleo diets, the true hunter-gatherers of the time, were developing coronary artery disease at an early age. A couple of presentations that didn't get as much press while we were there, but it's had more discussion now, and it's an old drug, isn't it? Digoxin. We still don't know how to use this drug, I think, Chris. Maybe you do, but I think many of us are still trying to figure it out. And again, we had an analysis from a cohort study that I think needs to be looked at with great caution. Another observational data set where we find that a drug looked like it may have increased mortality in a cohort of patients, but then a subgroup analysis from a randomized trial showed that at least perhaps hospitalizations could be reduced in patients with chronic heart failure. So I think more will come out about this drug in the next few years. I want to chat a bit about the Champion Phoenix trial. For this trial, DCRI had a key leadership role with both statistical resources, what Diane Gallup and the team, the CEC, including some of the fellows in the room, adjudicated many of the cases, and in fact, an old fellow, Sergio Leonardi, who's gone back to his homeland of Italy, led the effort. And Bob Harrington was one of the co-PIs, and several of us had the opportunity to participate on the executive committee. This is an important trial. Remember, this was a trial that had two major randomized controlled clinical trials done many years ago that did not show benefit with Cangalore, an intravenous P2Y12 inhibitor. This is basically the old AstraZeneca compound. They had ticagrelor and Cangalore. They sold the rights of Cangalore to the medicines company, who many of us have worked with for years. And despite those two negative trials, There were many that still felt that this was a drug that could work, and so they went ahead and raised a bunch of venture capital money and went ahead and did this randomized trial. I put this slide up because for many of you that work with operations people and non-physicians, non-clinicians on your projects, I think it's always really important to recognize the contribution that many people of the team make to the research. And so as you can see here, we had listed out all of the operations people that were involved in this trial for many, many years, as well as all the fellows that adjudicated the cases. And the satisfaction I've gotten from these people stopping me in the hallway and saying thank you for getting our names up there has really been tremendous. And I want people to reflect on that, because science now is team science. We have groups of people both within our own institution and across the globe that do a lot of this research, and we always have to remember the hardworking people that really make a lot of this research possible. Kangalore here showed what many of us thought it would show. Magnus actually had the ability to see these data before all of us because he was part of the Data Safety Monitoring Board. Great poker player, don't ever play against him because we never had any idea what was going on. But as you can see here, there was a little over an absolute 1% reduction in the primary efficacy endpoint, a composite, as you see here, of cardiovascular death, MI, ischemia-driven revascularization, and stent thrombosis. Highly statistically significant with a 22% relative risk reduction. This was driven primarily by a reduction in stent thrombosis and in myocardial infarction, as you can see here. So very important endpoints. There was a non-significant but still an important 26% reduction in ischemia-driven revascularization and no effect on mortality. This is very consistent with what we saw in the previous trials. The primary efficacy, safety endpoint rather, showed here very, very low gusto-severe bleeding rates just through 48 hours. So basically in the hospital setting, 0.16 versus 0.11 didn't reach statistical significance. But as you look at other markers of bleeding, you'll see that if you look at more sensitive markers of bleeding, such as acuity minor, TIMI minor bleeding, you'll see that there was a trend to more bleeding. Some of them reached statistical significance, which is what we'd expect. Shows that the drug had effect while it was on board, and yes, there is no free lunch. When we improve efficacy outcomes, we're likely going to get some more bleeding, whether or not it's minor or major. So onto the heart failure world. Several trials presented there, and there was actually 3 common themes, Chris and Mona. One, they were published in major journals all simultaneously. They all had great names: RED-AHF, RELAX, Astronaut, and the final common theme was absolutely no benefit on improving any meaningful outcomes. So I don't think this was a problem with the trials, Chris. I think the trials were all designed well. I think it's just our lack of understanding of some of these important interventions, and unfortunately it means job security for many of us. I guess that's the fortunate part. Unfortunately, we're not improving the care of patients, at least right now in heart failure, unlike we are in ACS.
Low event rates.
Low event rates. So another very important trial, 2 trials actually coming out from the partner program. One was the 3-year follow-up of the TAVI experience. It's important to highlight this because many people at the DCRI were involved in this trial. Pam Douglas and her team were responsible for reviewing all the echocardiograms in the Partner 1 trials. And Mitch Krukroff and an ex-Duke fellow and faculty member, John Peterson, now in Seattle, Washington, was also involved in a major way. And importantly, what we saw with the 3-year follow-up is there was no excess of mortality with the percutaneous device. And important, real stability of these devices in terms of the aortic valve area, so very important. I don't have the data to show you, but there's still this issue with the perivalvular leaks. showing more perivalvular leaks with the percutaneous devices. There is worse outcomes, but most of the leak is minor to moderate, and I think longer-term follow-up is still going to be important, even out longer than 3 years, for us to really understand these devices completely. The PARTNER 2 trial, now this leveraged the experience from PARTNER 1. This again was in the inoperable cohort, but now is looking at a second generation device, the SAPIEN XT device, which I don't know all the details. I don't play with these toys in the cath lab, as most of you know, but much more smaller profile, easier to get in through vascular access. And the thought would be that this would decrease vascular complications acutely and hopefully have similar long-term outcomes as the first generation device. And as you can see here, the event rates were really consistent across the two devices when you look at mortality with disabling stroke, hospitalizations, and then important composites of all these events. So very reassuring results that the modification in the device to make it easier to use didn't impact these important 30-day outcomes. And as you can see here, really the vascular and bleeding complications were much lower with the XT device here, 9.6% versus 15.5% for major vascular complications, and also for major bleeding events as well. So it'll be interesting to see how this plays out. I don't see any of our structural heart disease people to comment on this right now. They're probably up there trying to get these devices into people. So one of the big trials that we were all very interested in was the HPS2 Thrive. I think most of us knew the results before we actually got there, although when the details came out, I think we were really even struck again by the fact that there was really no benefit at all in important ischemic outcomes, but really consistent increase in significant adverse events with patients getting niacin compared to those not on the backbone of important and very well-managed statin therapy. So for now, I think that niacin is something that we really want to put on the back shelf in terms of managing patients with hyperlipidemia, and then many of the people in the audience are now getting involved in doing the trials with these PCSK9 inhibitors, which I hope will be the next step forward in the lipid arena. So I wish I could show you tax slides, despite multiple attempts that were not, how do the lawyers say it, did not respond immediately to questions and queries. They didn't send me their slides, and nor are they available on CardioSource, so I can't show you the slides. I don't know if this is by intent or not, but it's an important trial to recognize because many at the DCRI were involved in this. Dan Mark, Carrie Lee, and many others. And again, really provocative findings with this 2-by-2 randomization. We saw the chelation findings we saw those at the AHA in November, and now we saw the second factorial design with the vitamin therapy. And the cell that did the best was the vitamins and the chelation therapy. And Magnus, I think you were on the panel that saw this. Any thoughts as you've reflected on the data a bit more?
Well, this is a very controversial trial, and the reason you don't see the slides is because there's 2 lawsuits that are filed during the process of the trial regarding some of the aspects of the manufacturing of the chelation component, and so that's why none of this is released. It's not even published yet, and it's not in the pipeline for very soon either. So the findings are striking, and for those of you who don't see end-stage disease patients in the clinic, you should know that chelation therapy is very common in the western part of North Carolina. It's used a fair bit, and so this is something that you will come across in the state of North Carolina. It's a factorial design, and my criticism of the trial was that they presented one part in October or November November and the other part in March, even though it's all one trial, really should be presented together. The trial shows that chelation therapy is of borderline significance for benefit. The vitamins on their own had no benefit, but the cell that had the best outcome was the one that got vitamins plus chelation therapy, and the p-value for that was 0.01, which is fairly robust in a large trial like this. There's still a lot of controversy whether this is sort of a reasonable thing to suggest to patient, and I think the paper will obviously be very important. Just parenthetically, it's just one thing that really struck me that was interesting. So when Tony Lamas actually put the trial together, it was just straight chelation therapy. The chelation experts, the people who offer chelation therapy, said you've got to have vitamins in it. So what he did was kind of smart. He did a factorial design. And the interesting thing is the chelation people were convinced that without vitamins, the chelation therapy would be neutral. They were almost right. It's not quite right, but it's almost right. So this, I think, is one of the interesting things. Obviously, people who offer chelation therapy had a lot of experience. And so it's an interesting study. Paper to come.
Right. I do think the findings are really provocative because of the consistency of it across the endpoints that were looked at, both when you look at the first randomization and then the second randomization. The second thing is there's not a lot of safety issues with this therapy. But what I think many people still are continuing to struggle with is we don't really have a good hypothesis for why this works. And so people are just being cautious. Let's digest the data. You know, Chris, well, that oftentimes within the first few months of seeing data and being intrigued by it, often our perspectives change when we start looking at different subgroups and doing different analyses. Challenge is we're not going to be able to replicate this in any way. But I actually put a much more positive light on it than what's been put. I think Magnus even questioned, how come you're not being a little more excited about this and so cautionary in your presentation? I think that may reflect some of the issues.
Thanks, Ken. So we're going to keep going, and as we move towards more and more minimally invasive procedures in cardiology, there still remains a debate whether there's a role for off-pump CABG bypass surgery or whether it confers any benefit compared to on-pump. There's a lot of biological plausibility in reduction of strokes as well as in reduction of neurocognitive decline. However, no studies previously have been positive for any hard outcomes. So at the ACC this year, there were 3 trials comparing on versus off-pump CABG. And this is the first one. This was the coronary trial presented from Canada. And the patient population required at least one of the high-risk features, including either peripheral vascular disease, cerebrovascular disease, renal insufficiency, or age criteria. And as you can see, at 1 year, there was no difference in the primary endpoint of death, MI, stroke, or new renal failure between on versus off-pump CABG with a hazard ratio of 0.91 and the confidence interval crossing unity. So the authors concluded that there was no difference in the primary endpoint, there was no difference in the components of the primary endpoint, there was no difference in revascularization procedures, quality of life, or neurocognitive functions. The next one was the German off-pump CABG trial, and the entry criteria was a bit different. In this trial, patients over the age of 75 were enrolled. There were about 2,500 patients randomized, half of them to the off-pump CABG and half of them to the on-pump CABG. This slide illustrates that there was a crossover in both sides. Those who were randomized to off-pump, about 10% of them crossed over to on-pump, and majority of the reason was hemodynamic instability or myocardial ischemia intra-op, and about 5% actually randomized to on-pump crossed over to off-pump, and mainly this was because of a finding of calcified aorta. Again, this study was also negative as the coronary trial. At 12 months, there was no difference between the two groups in the primary composite endpoint of death, MI, stroke, repeat revascularization, and new renal replacement therapy. If you just look at the repeat revascularization, there was a small numerical but not statistical increase with repeat revascularization in the off-pump group. So the authors again concluded that there was no difference between the two strategies at 30 days and 12 months. But then the third one had a different design and a different study population, and interestingly a different result. So this was actually all patients from the same center, about 5 certified heart surgeons who had all performed over 100 off-pump procedures, and all patients had to have a Euro score of greater than or equal to 6. In this group, there's some perioperative characteristics just to highlight that the procedures in the on-pump, there were greater amount of distal anastomosis, and 2.66 compared to off-pump, which is 2.04. And the crossover was only in one direction, where the off-pump, about 8% of them actually crossed over to on-pump. The need for transfusion of blood was also lower in the off-pump compared to on-pump. And in this study, there was a difference between the two groups, with a reduction in the composite primary endpoint, which was the same, death, MI, stroke, or renal replacement therapy, of 20% in the on-pump group versus 9% in the off-pump group. And this was statistically significant. If you see that the primary endpoint is driven by acute MI, which is 12.1% versus 4.1%. And the question remains, what is the definition of a peri-procedural MI in a CABG setting, and what are the implications for this? The paper is not published, and certainly it would be important to know what criteria they used for the MI definition and whether that actually means anything. As we learn more and more about these peri-procedural MIs, we recognize that there is a threshold after which these may be prognostically important, and just a small bump in troponin or CK may not be. So certainly more to come from that regard. Also important to highlight that this study was positive, but it's all from the same center, and 5 surgeons who are experts at doing this procedure. So whether it's relevant and generalizable to all hospitals in our practice may not be there. The next study I want to discuss is the STREAM trial, and this was addressing something that Amit had looked at in his study with Tracy, that patients who actually live far away from a PCI center and are diagnosed with STEMI, should they actually be sent over for primary PCI, or should they receive thrombolytic? So this study was looked at patients who had early diagnosis of STEMI, so their symptom onset to diagnosis was less than 3 hours, and they lived far enough that they were not able to get primary PCI within 60 minutes of their STEMI diagnosis. They were randomized to either being transferred for primary PCI, which is, as expected, would take longer than 60 minutes, or they should undergo a pharmacoinvasive therapy, which is being thrombolyzed, and then if they do not reperfuse, getting rescue PCI, or if they do reperfuse based on an ST segment resolution on ECG, they get early invasive strategy, which means getting a cath and appropriate revascularization within 6 to 24 hours. Earlier on in the study, it was recognized that patients who were over the age of 75 and getting thrombolytic therapy had an increased risk of intracranial hemorrhage. So the DSMB changed the protocol, or recommended to change the protocol, to half dose thrombolytic in the over age 75 group. The top line highlights that there was a difference, as expected, in the time from onset of symptoms to receiving therapy in the pharmacoinvasive versus the primary PCI groups, a median of 100 minutes to 178. But this 100 minutes is very, very, very good in terms of this is onset of symptoms, not from the diagnosis. So this is patients are receiving their therapy very quickly. So it's important to recognize that this may not apply to those patients who don't present early. Patients who get thrombolyzed, about 64% of them required non-urgent, so they reperfused and they got their angiography within 6 to 24 hours at a median of 17 hours. And 36% of them required rescue or urgent PCI. Between the two groups, the primary endpoint, which was a composite of death, shock, recurrent MI, or heart failure, was not different between the two groups. 12.4% in the pharmacoinvasive group versus 14.3% in the primary PCI, and this was not statistically significant. But so that's the two groups. And then if you're looking at the subgroups, there was a trend towards lower heart failure and cardiogenic shock in those in the pharmacoinvasive group, numerically lower event rate, but statistically insignificant. In regards to stroke, all strokes were significantly increased in the pharmacoinvasive group, as would be expected with thrombolytic therapy, 1.6% compared to 0.5%. But the one that's highlighted is after the amendment or the change of the dose of the thrombolytic therapy, there was no difference in the intracranial hemorrhage rate, 0.5% versus 0.3%. So the authors concluded that the pharmacoinvasive therapy is as effective as primary PCI in STEMI patients presenting within 3 hours of symptom onset who cannot undergo primary PCI within 1 hour of first medical contact, is associated with a small increased risk of intracranial bleeding, and provides the opportunity for a measured approach to invasive coronary interventions, circumventing an urgent procedure in about 2/3 of fibrinolytic-treated STEMI patients. So I think this is something that may be worth highlighting and discussing how it changes practice here, and if anybody has any opinion on that.
So these were sites that had the capability to do PCI?
Where the diagnosis was made was at least 60 minutes away,
60 minutes away.
From a PCI center.
So if you randomized to pharmacoinvasive and required an urgent cath, then you really were adding a significant amount of time to revascularization. I assume that a lot of those were included vessels when they got to the lab.
Correct. So 36% of them required urgent because they did not reperfuse.
That would be 100 minutes plus another
The transfer time.
which would be another
Correct.
60 minutes or so.
So also one of the other things I didn't discuss is that 80% of patients actually got thrombolytic by the paramedics, and only 20% got it in the hospital. So to be able for a paramedic to give a thrombolytic, you have to have a system where, one, the ECG is done, second, the diagnosis is confirmed, you rule out all the contraindications to thrombolytic, and then be administering. So you have to have a system placed. And I think, at least in lots of parts of the States, even the system for pre-hospital electrocardiograms, a patient coming into hospital where EMS requires further work.
So Magnus, you're on the hotline called Fellow in CCU tonight, and they get a call. Do you think, and the patient showed up within 2 hours of symptoms. Now how does this change the decision when we're starting to really think you got to have them on the table here in an hour to get these kind of results, or do you not buy it?
Well, so this is a very unusual trial. It responded positively. It's a neutral trial.
It's a neutral
It
trial.
shows no benefit either
Great.
strategy, but it's not showing equivalent, which is the statistical term. There's no boundaries was placed around how good
Right.
the treatment A or treatment B had to be equivalent.
Right.
So this leaves us sort of very much in the dark. It's a nice trial to do. It says that it's feasible and that it can be done, and that we learned that you shouldn't give full dose lytics, so that's a good thing in the elderly. But technically, once you modify a protocol, you should also modify sample size. They never achieved the full sample size. So this is sort of an unusual trial of some interest, but I don't think will change practice.
I think if you put yourself in a position where you're about 75 minutes away and you're the one who's having a STEMI, I would think, based on this trial, I wouldn't change the practice. I probably would want to come for primary PCI, especially if I'm an early presenter, or not if I'm not an early presenter, because these results are only applicable if you actually diagnose the STEMI early and be able to reperfuse the patient, because as the time from symptom onset to thrombolytic administration increases, the response rate certainly decreases. And just finally, just to cover a stent trial, this is exploring the Nobori biolimus-eluting stent, which is the drug is biolimus, and instead of on a durable polymer, this is on a biodegradable polymer, polylactic acid, and this was compared against the gold standard, which is the everolimus-eluting stent, the Zions V stent. Majority of the patients in this study were stable ischemic disease, and about 20% had acute coronary syndrome. There was no difference in the primary endpoint of target lesion revascularization at 1 year. In addition, the angiographic component of the study showed no difference in in-segment late loss between the two groups. And finally, there was no concerns regarding increased stent thrombosis with this stent compared to the gold standard, which is the everolimus eluting stent.
Great, thanks. So thanks, Akshay. That was terrific. So just to wrap up here, I think we all had, or those who had the opportunity to be in San Francisco, all had a great time. And it was a great weather for people who don't know the city. The weather that we had there was unbelievable for this time of year. And Lydia Califf told me a story. She was actually in her hotel room on Monday morning, and she said, Rob was saying, what are you going to go do? What are you doing today? And she said, I'm going to go walk the Golden Gate Bridge. And she said, Rob looked at her and said, why, I think I'll join you. And Lydia almost passed out. And she said, maybe he doesn't need to work all the time. But unfortunately, he was sitting there reading his BlackBerry. At least he was out. He was still trying to get some work done, probably torturing many of us to get more work done. But just to wrap it up, I hope this was informative, some good discussion. I want to thank Akshay and Connie for contributing a lot to this as well. But I want everybody to reflect on what we've accomplished here, and that when you go back and you look at what our missions are, both the DCRI research group is outlined here to really develop and share knowledge that improves the care of patients around the world. I think that we achieved that mission, at least in part, with all of the great science that was done leading up to the meetings, and the way we presented the science and interpreted the science, and hopefully how we'll think about implementing the science here in our clinical care. And then I think it also reflects nicely on the Duke Heart Center mission and vision of really bringing in groups across our health system to care for these patients. And the data that we've generated, the data that we've analyzed and thought about is going to be critical as well from a heart center perspective. So thanks for your time and attention this evening, and happy to have Akshay and Connie come back up and have any more discussion or let people get on their ways. Thank you.